Dr. Campeau is a nuclear medicine physician, comes to us from New Orleans, and he's going to talk to us about lutetium-177. Lutetium-177 and the high-dose long-acting octreotide study.
Ready? Thank you for inviting me. Wow, such a turnout. It's good to be here. How many, I'm just kind of curious, how many principal investigators are in the audience, docs, PIs, on the AAA study? Not many. One, two. Okay. You can. The PRRT has been in use in the EU for 2 decades at least, 1991, 1992 or so. First with indium-111 pentatriotide, and then subsequently with yttrium-90 DOTATATE, and more recently with lutetium-177 DOTATATE. What I'd like to do is kind of go over some of the information, some of which I got this morning actually from the sponsor, AAA. I'd like to preface my talk first with a slide here showing a patient with a very prominent partial response to peptide receptor radionuclide therapy. This is a mid-gut carcinoid patient with a pretty high upper level of intermediate Ki-67 of 20%. The slide on the left is the gallium DOTATATE images before up on the upper left, and 3 months after his last cycle of peptide receptor radionuclide therapy. And what you can see is a very prominent partial response that has persisted for 34 months, despite that elevated intermediate level of Ki-67. Some people are now looking at Ki-67 as a low, there's a low G2 and a high G2. Low G2s being below 10% or so, higher G2s being the 10 to 20%. And there seems to be less of a good prognosis when you're up in the higher intermediate levels. This is a complete response of a mid-gut carcinoid from the bone people. This patient had multiple metastatic liver lesions shown with the arrows before PRRT, and then 3 months after his last cycle of PRRT, you see complete response, which was also borne out on octreoscan images. I'm pretty excited about doing PRRT. We're almost getting there, and it's going to be an additional modality in the armamentarium. My colleague, Dr. Waltering, said that I was yesterday the world's expert on I-131 MIBG treatment, which is kind of interesting because I've only been there for 6 years. My first patient was in June of 2008, and I've done about 60 of those so far. But I'm really excited about doing peptide receptor radiotherapy. The NETA-1, as it's called, or AAA trial, is the first phase 3 multi-center stratified, open, and randomized controlled parallel group study that compares lutetium-177 dotatate with high dose, meaning 60 milligrams of octreotide LAR with patients that have inoperable and progressive via RECIST criteria, somatostatin receptor positive midgut carcinoid tumors. In study centers, 32 European centers and 14 USA centers. I have to update the slide a little bit later at the end when I learned this morning that there are 15 United States centers and 36 European centers now. Sponsor, as you know, is Advanced Accelerator Applications, or AAA. And the study objectives I'm going to go over involve, with study objectives, key criteria for enrollment and treatments and assessments will be discussed in the following slides. So the NETA-1 is the first phase 3 multicentric stratified. I think I've got 2 of those. Let me jump to that. These are the participating sites, and I got to update this at 51 sites, 36 in Europe and 15 in the United States. And interestingly, I counted through there, and I only count 14 in the United States, but that's why I ask any of the principal investigators here. They can update me or make comments. So 36 in Europe and 15. So we have 51 sites for the phase 3 study. In the study, treatment with lutetium dotatate plus best supportive care, 30 milligrams of octreotide LAR, it will be compared to treatment with high dose LAR in well-differentiated G1, G2 carcinoid tumors, midgut carcinoids that have progressed and verified centrally by CT, MR. The objective tumor response is going to be centrally assessed in both arms every 12 weeks from the first treatment date, according to RECIST criteria. Efficacy is blindly and independently assessed through image review by qualified readers. Patients in both study arms will be evaluated for safety and tolerability centrally. The primary objective is progression-free survival. Progression-free survival after treatment with lutetium-177 dotatate compared to high-dose octreotide LAR treatment with 60 milligrams in patients with inoperable progressive somatostatin receptor positive, well-differentiated midgut carcinoid tumors. Some of the main secondary objectives to compare objective response rate between the 2 study arms, to compare overall survival between the 2 arms, and to compare time to tumor progression between the 2 arms. Also to evaluate safety and tolerability of lutetium-177 dotatate, and to evaluate health-related quality of life. As a separate sub-study, dosimetry, pharmacokinetics, and ECG evaluation will be performed in about 20 patients at 2 centers or so, I believe. The inclusion criteria are as follows. You have to have presence of inoperable, i.e. curative intent to midgut tumor, and histologically proven and assessed centrally. Ki-67 index must be less than 20%. In patients on LAR at a fixed dose of 20 to 30 milligrams monthly for at least 12 weeks prior to enrollment. Patients have to be over 18 years of age, and they must demonstrate progressive disease per RECIST 1.1 criteria on CT and MRI scans. All of the tumors have to be somatostatin receptor positive. The tumors are documented by CT, MRI scans, and based on positive arteria scan imaging with uptake at least up to the liver, if not greater than the liver. Karnofsky performance score has to be above 60, and there needs to be a presence of at least one measurable site of disease, which changed in RECIST 1.1 from the previous RECIST. The exclusion criteria, the serum creatinine over 1.7 milligrams per deciliter, total bilirubin greater than 3 times the upper limit of normal, not anemic, hemoglobin with less than 8, white cells less than 2,000 excludes patients, and platelets less than 75,000 per cubic millimeter. Treatment with greater than 30 milligrams of octreotide LAR will exclude a patient within 12 weeks prior to enrollment, If they've had PRRT at any time prior to enrollment, they're excluded. Targeted surgery, external beam radiotherapy, chemotherapy, embolization, mTOR inhibitors, etc., and other investigational therapy within 3 months before enrollment excludes people. Uncontrolled heart failure, even as low as New York Heart Association Class 2, and certainly 3 and 4, or diabetes defined as a fasting glucose over 2 times upper limit of normal. Patients with any significant medical, psychiatric, or other conditions which would interfere with completion of the study are excluded, and of course pregnancy. The duration of the study will be 32 months total, 14 months of recruitment and 18 months treatment and assessments until the end of study. The end of study is defined as when the last enrolled patient has completed 76 weeks of assessments after the patient's first treatment in either arm of the study. Other data include long-term toxicity suspected in relation to the study, hematology, biochemistry, urinalysis, etc., as well as progression-free survival based on local assessments, and overall survival data will be collected every 6 months now for initially 3 years, now 5 years after the end of the study. This is kind of a summary of the protocol schedule in each arm, and this has been increased 115 patients. They're treated with 8 weeks each, 4 doses of 200 millicuries, 7.4 gigabecquerels, at 0, 8, 16, and 24 weeks, for a total of 800 millicuries cumulatively. And progression-free survival is assessed every 12 weeks, and then there's a 5-year follow-up after the end of the study. The study duration is 32 months total, with 14 months of recruitment and 18 months of treatment until the end of the study, and then for 5 years of follow-up, as I mentioned before. The end of study is defined when the last enrolled patient has completed 76 weeks of assessments after the patient's first treatment in either arm of the study. Other data include long-term toxicities suspected in relation to the study drug, as well as progression-free survival. And overall survival data is collected every 6 months for 5 years after the EOS. Sorry. The treatments consist of a cumulative dosage of 29.6 gigabecquerels, or 800 millicuries, of lutetium given over 16 weeks, with best supportive care of 30 milligrams of LAR for symptom control until the end of the study, unless the patient progresses or dies. The administrations are given at 8-week intervals, all 200 millicuries, with concomitant amino acid infusions for kidney protection. And then in either arm, if in case patients experience symptoms, diarrhea, flushing, etc., sub-Q octreotide rescue injections are allowed. In the octreotide LAR arm, 60 milligrams of LAR is given every 4 weeks via IM injections until the end of the study, unless the patient progresses or expires. And as in the lutetium DOTATATE arm, patients that experience symptoms also can receive sub-Q rescue injections. This is the enrollment curve, and it basically shows as of September, and I have some update on this morning. There are 261 patients that have now been consented, and the enrollment is rapidly coming to an end. The recruitment is still ongoing. The first patient was enrolled in July of 2012. The Data Safety Monitoring Board is supervising the conduct of the study and regularly assesses the outcomes. After reviewing the safety data during the last meeting, which was August of last month, the Data Safety Board Data Safety Monitoring Board's advice was to continue the study as described in the protocol without any changes. So the future work in scheduled analysis, the analysis of the primary endpoint will start after 74 evaluable and centrally confirmed disease progressions or death events. Once the primary endpoint has been reached, patients who have completed their treatment path according to the study protocol will enter long-term follow-up assessment phase over 5 years. The end of study shall take place after 158 deaths, or the 5-year follow-up period, whichever occurs first. Overall survival analysis will be performed at that time, and a dosimetry, pharmacokinetics, and ECG sub-study will be conducted in a subset of 20 patients at, as far as I know, 2 selected sites to provide a complete assessment of lutetium dotatate's safety. I'd like to end here with a follow-up dotatate PET CT scan in a patient with a very prominent partial response of bone metastases 3 months post PRRT. The slide A and B on the left are before A dotatate scan, gallium dotatox scan, sorry. At 3 months before is A, and then 3 months after he's received his last PRRT cycle, and this patient has metastatic midgut carcinoid with bone mets. And we see, depending on the literature, it varies, probably around 20% of the midguts will have bone mets. It may run a little higher or a little lower, depending. But of the patients with the bone mets, probably only 25% of that 25% actually have bone pain. Bone pain is well treated actually with PRRT, and many patients tend to notice within the first week or so improvement, and improvement goes to about 50% of significant improvement of bone pain. And then, as you know, many people, many carcinoid with patients with bone mets don't have bone pain, and we find that's not what kills them. The liver gets them. So the latest news this morning is that 262 patients have been consented, and of the 262 patients, 172 have been randomized. The remaining 56 are screen failures, and there are 34 remaining patients that are in the screening phase now. The end of the enrollment, as I mentioned, is approaching. The main study will be closed in mid-November of 2014. I'd like to thank you for inviting me, and just a quick summary. Peptide receptor radionuclide therapy is an efficient treatment for GEPNETs. It has a very good overall response rate and survivals. I'd like to just last say one thing. How many people here are familiar with the Right to Try Act? Anybody? There's a couple in here. Interesting. There are 4 states, Louisiana happens to be one of them, Missouri, Arizona, and Colorado, and correct me if there's been any yesterday or whatnot, but 4 states have the ability, or will have the ability, to administer investigational drugs to patients with terminal illnesses, assuming that we can prove that they have done at least phase 1 in terms of safety and efficacy. This is an interesting alternative to a trial like AAA. The FDA is not real happy about it, nor are the medical board, state boards of medical examiners, etc. But it does allow someone like myself to get up and running, as I did with MIBG, to get up and running with PRRT without going through an IND, et cetera. So that'll be interesting to see what develops there. So thank you very much for your attention, and